Hi, welcome to Healthcare. It is Tuesday, February 13th, and we are taking up for most of the afternoon page 233, which is pharmacy benefit managers and other things. We're going to start with Jen. So Jen did the walkthrough of the bill, but she also put together a document that looks at what is currently in statute and what this is new for this bill. So we're going to walk through that to start us off and make sure we're all on the same page, and then we'll hear from the witnesses. So Jen.
Great. Good afternoon. Jennifer Kirby, Office of Legislative Counsel. So yes, as the chair said, I have a comparison. I had done something like this when we looked at PBM bill a couple of years ago. I think it's helpful in this case in particular because everything looks new in section 1 because it's all being codified in one place. But a lot of it is existing law or minor tweaks to existing law. So I thought it would be helpful for you to have a sense for what is actually new and what is not. I did not go through every definition, but I did go through many of them, or some of them. So I did not put in the purpose, that's just the purpose section. But in section 1, which is again, all that big new chapter in 18 BSA, what would be 3602 subdivision 6, there's a definition of maximum allowable cost. That's a term that gets used in the bill, and that is the same as in existing statute. So even though it's underlined, it's not actually new to the law, just new to this location.
Jen, I'm just going to stop you real quick.
Yeah.
So we are on page 4, row 3.
Oh.
6.
Yes, so page 4, line 3.
Be helpful.
Number 6.
Number 6, yeah, so line 3, yes, it's the same as existing law. And we can look at other ones of these, but I was just trying to hit a few of the ones that are particularly relevant.
Yeah.
Definition of pharmacy, which is on page 5, line 3. This is not the same as the definitions that we have so far in statute. It's more descriptive than most, although there are some similarities to the definition in the regulated drugs chapter. This, and just my note tells you that the new definition comes from the NCOIL, the National Conference of Insurance Legislators. Is that what I'm remembering? Model legislation. And there's a definition of pharmacy benefit management. So that's just below it, number 11 on page 5. And that is very similar to the definition of in 18 BSA 9471. I think there may be a word or two that's different, but for all intents and purposes, it's the same.
And
Yes.
just from the pharmacy,
Yes.
that definition, and I don't know whether we want to get into this or not, but they also provide vaccinations.
They're covered.
It is?
I mean, it's a place licensed by the Vermont Board of Pharmacy at which drugs, chemicals, medicines, prescriptions, and poisons, which is the old-fashioned sense of poisons, are compounded, dispensed, or sold in retail. We can
Vaccination.
I mean, we can tweak it if you want, but I think that in order to qualify as a pharmacy, you need to do those things. If you're also administering vaccinations, it doesn't take you out of the definition of pharmacy.
Okay. Let's move along.
We can revisit if people want. All right, in section 1, in what would be 18 VSA 3603, starting on page 6, is rulemaking, DFR rulemaking. And this is a new section on DFR rulemaking that is, there is existing DFR rulemaking in 18 VSA 9421, but it's more narrowly tailored to rulemaking for that one section, implementing the section, and then DFR has very broad rulemaking authority generally. But this language in the bill, the rulemaking authority is broader, and it is specifically new to the statute. It would include a requirement that PBMs file their advertising and solicitation materials with the commissioner for approval before sending those materials to patients or consumers. So that would be new, that the PBMs file those. Section 1, ATVSA 3604, also on page 7, would have DFR doing annual reporting on how PBMs are complying with the provisions of the chapter. That's a new provision. There's nothing like that in existing statute. Then we get into the subchapter on licensure and regulations. We're still on page 7, 18 VSA 3611. Would be in the bill, the new PBM licensure requirement, including a $100 application fee and a $500 annual licensure fee. There's certainly a lot more detail about the licensure, but the point is licensure is a new concept for PBMs. It's not in current law. So in existing law, the state requires PBMs to register with DFR and allows DFR to charge PBMs for the department's reasonable expenses in administering the section, but it is not an affirmative licensure requirement with annual licensure fees. Then in 3612, which starts at the bottom of page 8, these are PBM prohibited practices with respect to pharmacies and pharmacists. And a lot of these are the same as an existing statute. They're just being kind of centrally located here. So prohibiting pharmacies and pharmacists from disclosing healthcare information, a whole list of things. That is already an existing law. These are some of the provisions that were added in Act 131 from a couple of years ago. So they're newer to the statutes, but they are already in statute. Same thing with prohibiting PBMs from prohibiting pharmacies and pharmacists from discussing the total cost of pharmacist services for a drug, providing cost-sharing information to a beneficiary, disclosing the cash price for a drug, or selling a more affordable alternative if one is available. That's already in statute. Provisions around prohibiting PBMs from prohibiting pharmacies and pharmacists from disclosing information to DFR, law enforcement, or state or federal government. I don't know if you're following along in the bill. This is on the bottom of page 9, top of page 10. That's the same as an existing statute. Prohibiting PBMs from terminating a contract with or penalizing a pharmacy or pharmacist for disclosing information about PBM practices, except trade secrets, or sharing the contract with DFR for compliance purposes. That's an existing law.
Can I stop you there, Jen?
Yeah.
Sorry, because we're going fast. So I just want to make sure when we're starting on 3612 prohibited practices. Everything on page 9 and 10 so far is current law.
Yes,
Okay, thank you.
Everything on 10? Yeah.
I believe so.
Okay.
We then went through and compared, but it's all manual comparison, so
Yep.
possible I made a mistake. All right, and then toward the bottom of page 10 and onto page 11, prohibiting PBMs from requiring a beneficiary to pay more than the lesser of cost sharing under the plan, amount under their plan, the maximum allowable cost, or the cash price. That's the same as an existing law. But now we get to a new one. And that is on the top of page 12. The bill would prohibit PBMs from conducting or participating in spread pricing in the state. And as you see in the chart, there is no similar provision in current law. And then I skipped over it a little bit because it was in the list of prohibited practices, but also back on page 11 was the requirement that PBMs attribute any amount paid by or on behalf of the patient toward their deductible and out-of-pocket maximums. So that is what people are sometimes referring to as the copay accumulator. There is no provision for that in existing law.
That's page 11.
Page 11,
Number 3.
subdivision 3.
Right, okay.
Subdivision E3.
So sorry, Jen, Alyssa has a.
Is there a definition of spread pricing?
There is not in here. although there is a bit of a description of it elsewhere.
You're saying 3 on 11 is new?
Is new. 3 on page 11 is new. Yes, technically, I think so. It's 2, but it gets very specific. All right. Then we get into NTVSA 3613, which is the DFR enforcement of the chapter. There is some similar language, similar concept around enforcement. 18 VSA 9474 is the existing section on enforcement of the PBM laws. It gives authority to DFR to enforce, but it also deems a violation of the subchapter on PBM regulation to be a violation of the Vermont Consumer Protection Act with a role in it for the Attorney General. The bill's provisions are just entirely different. So different way of doing enforcement gives a role to the Office of the Healthcare Advocate that they don't have an existing law. It's just completely different.
This is all new.
All new.
Okay.
Yeah, so there is an existing section on enforcement, but it looks. Section 3614 on page 13 is entitled Compliance and Consistency with Federal Law. There is no similar provision in existing law, although in general, we are not intending to conflict with applicable federal law. Then we get into 3615. Charges for examinations, applications, reviews, and investigations. As I mentioned earlier, there's an existing provision that allows DFR to charge PBMs for the department's reasonable expenses in administering a particular section of statute. And the note here tells you that the current provision is limited to administering 18 VSA 9421 only. H233 would allow DFR to charge PBMs for the department's reasonable expenses in administering the entire chapter. Then we get into a new subchapter starting on page 14 of the bill, which is PBM relations with health insurers. And so the first section of that, 18 VSA 3621, requires the an insurer's audit of PBM activities to verify that there is full pass-through happening of all rebates and discounts. So in the existing law, it requires the PBM to allow access to their information in order to allow the audit to verify that full pass-through is occurring. 3622, it starts on page 15.
You said the previous one was in new.
No, 3621 is the same as existing law, same as 18 VSA 9421. That's okay. It's just in your chart. So 3622 is PBM required practices with respect to health insurers. There are a lot of the same ones. I did note, because one of these is about disclosing the amount of any spread pricing, and the reference to disclosing spread pricing should probably be removed. If you go with the bill the way it's written, because as written, the bill would ban spread pricing, so there isn't really a need to report on how much.
And what number is it?
Now I'm looking.
Okay, it's fixed.
Thank you. Subdivision E on page 19, we're just getting there. Yes, at least annually. So this is the kind of description of spread pricing. At least annually, the PBM would have to disclose to the health insurer, DFR, the Green Mountain Care Board, and the Office of the Healthcare Advocate the aggregate, and this is an existing law as well, the aggregate amount the PBM retained on all claims charged to the insurer for prescriptions filled during the preceding year in excess of the amount that the PBM reimbursed pharmacies, and how much they held on to. That is the concept of spread pricing. That is existing law, but it's a little internally inconsistent if the bill is also banning spread pricing. So just that notice there to remind you and me that may need to come out.
Okay.
Depending on what you decide to do. So that is 36 VSA 3622 PBM practices with respect to health insurers. The language is the same, but may need to be tinkered with depending on what you do. Then we get to the next subchapter, which is PBM relations with pharmacies. This starts on page 19. Some of these are the same, some of them are not. So these are PBM required practices with respect to pharmacies, to the requirement to pay a claim or provide notice of a contest or denial within 14 days is the same. Prohibiting requirement that the PBM pass through a portion of the copay, referring to here as clawback, to the PBM, the setting the maximum allowable cost, some parameters around what that looks like. So provision in the bill that is not an existing statute is that if a PBM denies an appeal without identifying an alternative purchasing option, then, and the reimbursement amount is less than the pharmacy's actual acquisition cost plus a reasonable dispensing fee, the insurer would be on the hook to reimburse the pharmacy for the balance. And that is on page 22. So that would be new. That subsection D is new. In the bill and an existing law, a PBM cannot reimburse unaffiliated pharmacies less than they reimburse PBM affiliated pharmacies for the same services. But the bill would add, and that's why it's in bold, and the reimbursement amount must be based on the pharmacy's actual acquisition cost plus a dispensing fee that is at least as much as in the Medicaid program. That is in subsection E on page 22. So that second sentence is really what's new, starting on line 12. And then the rest of that section is the same as existing law. So can't place any restrictions on pharmacies that are in excess of those required by state or federal law. PBMs must provide notice to pharmacies before they change the formulary, and a number of protections for 340B covered entities and the patients who use them. And those are all the same as existing law. Section 2 is so we've moved out of that new chapter. Section 2 is amending, it says 18, it should say 8 VSA 4804. We're in the insurance chapter, or insurance title. And this is adding PBMs to an existing prohibition on using advertising practices related to insurance that are materially misleading or deceptive. So the provision itself that prohibits insurance companies from using advertising copy or advertising practices for plans of solicitation that are materially misleading or deceptive, that's all existing law. The fact that PBMs would be added to that statute, that's the new part. That's on page 24, 25. Also on page 25 is 8 VSA section 4089J. And this section prohibits insurers and PBMs from excluding amounts paid by or on behalf of a covered person from deductible or out-of-pocket maximums. That's the meaning it requires the copay accumulator. These are all new sections. So I said I'm deciphering my little shorthand here, but new provisions added to existing statute on filling a prescription. So it's an existing statute, but these are all new provisions in the left-hand column that were being added. So it prohibits insurers and PBMs from regulating prescription drugs, pharmacies, or pharmacists in a manner that is more restrictive than or inconsistent with state or federal law or Board of Pharmacy rules. That's on page 26. Prohibiting PBMs and pharmacies from directly soliciting insurers in most circumstances. Bottom of page 26 and on to page 27. and prohibiting an insurer PBM from altering a patient's prescription drug order or choice of pharmacy without the patient's consent. That's in the middle of page 27. Section 4 is the direction to AHS, the Agency of Human Services, with a stakeholder group to do a competitive bidding process and administer a program for a wholesale drug distributor who would be the sole source to distribute drugs to community and outpatient pharmacies for Medicaid beneficiaries. This is a section we did not walk through the other day. It is not the same as in current law, although similar language has been proposed a couple of times in 2022 and in 2017. Section 5 are the repeals. It would repeal existing statutes. Those are all the ones that were subsumed into that big new chapter in section 1 of the bill. And then finally, the applicability and effective dates, section 6 and 7. We are now on page 31, the last page of the bill. The act would take effect on July 1st, 2023. Section 1, the new chapter on PBMs, would apply to contracts and plans. You'd say issued, offered, or renewed on or after January 1st, 2024. Obviously, these dates all would need to be updated. And PBMs operating in Vermont on that date would have 6 months to come into compliance with the licensure and regulation requirements. So the effective date needs some updating, effective date and applicability, because the bill was introduced in 2023.
Great. Thank you, Jen. That walkthrough is very helpful. I'm sure we'll be coming back to that spreadsheet. Okay, so we're gonna start hearing from people. And Lauren Bode. Hi. Oh, you're here. Great. Come on here. And I'm sorry, is it Bode?
Bodie.
Bode. Okay, great. So welcome.
Here.
And do you have anything to put on the screen, or are you just talking to?
I'm just going to speak more generally first.
Great. So if you can introduce yourself for the record, and then I think you are talking to us about like the why. Okay.
So I'm Dr. Lauren Bode. I am a pharmacist and also the executive director for the Vermont Pharmacists Association. And I know that I've addressed some of you before, but for those of you I haven't, I'll kind of explain just a little bit about like what I do. Because I am a pharmacist who does not ever touch medication. And that's the face that I get. I'm a little flummoxed. So how could it be that you are a pharmacist and you don't touch medication? And this is because I've been to 10 years of education and training. And I'll tell you that there was not any moment of it where they were telling me about how to put medications in a bottle. What I did go to 4 years of undergrad, 4 years of pharmacy school, 2 years of residency for, is to make sure that the medications that are being used are the most appropriate ones and how to care for the patient who is using them. So what I spend my days doing is I work in a primary care clinic, helping people manage their chronic diseases, in particular diabetes, hypertension, and heart failure. And so my only interaction with medication is through the patient who is actually taking it. And so similarly, I would say that the value of community pharmacy in our state is not wholly encompassed by just the medication that it sells. The true value of pharmacy is the highly trained pharmacist that is there. So what we know, and which will forgive me for slipping into my academician mode for just a second, is that we have hundreds of studies that have shown these things to be true, is that when a pharmacist is more involved in a patient's care, 3 things happen. Treatment outcomes improve, patients are happier with their care, and their care costs the healthcare system less. And this isn't surprising when you again think about the level of education and training that goes into becoming a pharmacist. So if you're kind of adding up those years with me of the undergraduate work and the 4 years of a clinical doctorate, plus maybe some additional residency training, you're probably recognizing that this is quite substantively similar to the level of education and training that many healthcare providers in the rest of our system that we seek out for our care, and you would be correct. The, what is substantively different, if it's not in our education and training, it's how pharmacists are currently monitored and valued by the healthcare system. So I'll speak from, my standpoint of, if a patient comes into the clinic I work in and say they have a headache and a stuffy nose, the provider would review their history, check their blood pressure, and, assuming their blood pressure wasn't too high, recommend pseudoephedrine, or failing that, some Flonase. And for that visit, they would bill for an office visit and would be reimbursed approximately $90 for the 2024 Medicare fee schedule. And it's generally understood that even if the provider is spending, let's say, 7 or 8 minutes with that patient, that $90 is covering that 7 to 8 minutes and the wealth of experience that goes into that visit, and then the support staff and the amount of money that it takes to keep the lights on in that clinic. Now, if the same patient came into a pharmacy that I worked at, the pharmacist would review their history, perhaps check their blood pressure, and if the blood pressure was not too high, recommend some pseudoephedrine, or failing that, some Flonase. And for the same service, and for really any medication that this pharmacist would dispense in the community pharmacy that day, they would be reimbursed approximately nothing, because that's what the PBM can decide to do. And they do frequently. So taking this also that, a patient of mine last week told me that he went to pick up the insulin I prescribed, and that pharmacist in the community spent 40 minutes with him talking with him about his diabetes. And I know that not only did that pharmacist have any professional fee that was associated with that 40 minutes that they spent with the patient, but I also know it's extremely likely that the pharmacy lost money on the insulin prescription that they dispensed. I also know that that patient is also on Jardiance. And so I also know that that pharmacy is losing money every single month when they fill that patient's Jardiance prescription, because that's what the patient needs to be healthy. So this bill is important to advance this session because it sustains and fleshes out a financial framework for allowing pharmacists to do their essential job of taking care of Vermonters. And as a reminder, 15 years ago, there were over 50 independent pharmacies in Vermont, and we're down to 18 now. We have seen this, we have lived this over and over, that that hole in the community that happens when we lose a community pharmacy, and it's continuing to happen, and it will continue to happen without some essential changes. And so with that loss, it's obviously practically important for patients to be able to access the medications that they need, but it's also creating a hole in the healthcare fabric of Vermont that is not going to be able to be readily filled. And what I can say for certain is that, we need those highly trained pharmacists here in our community taking care of our patients, because while the medication in the bottle is important, if it's not the right medication, that's limited utility. And it's the pharmacist and the pharmacy staff on the ground that make sure that it is the right medication for that patient. So that's what's at stake. I know that this every time that I engage with anyone in a conversation about PBMs, a few things happen. One is it gets very complicated really quickly. The other thing, though, that I think is important to remember is if we can stick with that complexity, by the time we get to the end of the conversation, the general response that I get from people is, wait, really? How is that possibly okay? And the answer is it's not. So thank you for addressing this. I appreciate the attention. I appreciate you embracing the complexity. It's needed and appreciated. So I'll certainly answer any questions if you have them for me, but I think that we do have a lot of other people who are going to be sharing their particular expertise on some of that complexity. And so I'll also gladly cede my chair to those folks.
Thank you. Does anyone have any questions? Alyssa?
Is there anything not in the bill?
That needs to be?
Yeah.
So, so I spent some time reading the guiding principles. And, what stood out for me is I think that there are a lot of things where I look on that list where I think pharmacists and pharmacy can be the answer to some of the problems there. I think that there's I think and I would love at some point, probably not in this legislative session, to like talk about some things of like payment parity for pharmacists. But for today, I'm content to address like 233. I think it's a substantive step and one that would provide a much needed fix that's needed now. In particular, like in 2024, as there's been some changes in how Medicare is adjusting payment. And so while I would welcome the conversation, I also would love to sort of like drill in on like 233 because I think it has some of the most like substantive things we need at the moment.
Yes, how many folks go to someone like you at a pharmacy to get their health care? You cited the example of someone going to you. And to me, I've never done that. So I'm trying to wonder, what percentage of people that are sick go to a pharmacy without going to the doctor first, if it's that.
Well, so I think that it's not necessarily like an either or. I mean, so the example I gave was someone who's like seeking out treatment for a minor ailment. It's, that would likely respond to an over-the-counter medication.
Yeah.
And I think this is, one of like the key ways that pharmacists are like serving their community by being readily accessible to help advise like treatment decisions that a patient would otherwise be left to do for themselves. Sometimes it's also the pharmacist though, who does that initial like assessment and triage and goes, oh, actually, I really do need you to go see your provider.
Right.
And so I think about a time where someone came in and asked the pharmacist, oh, hey, where's your hydrocortisone cream? And the pharmacist was like, over there, but like, why? What's going on? And long and the story short of it, what was going on is the patient had a really severe skin infection that required immediate treatment. And there's no mail order pharmacist that would have been able to make that intervention and refer that patient to get care. And so I think that's where like we need these fixes to make sure that we have this healthcare center in our community, in addition to being able to access necessary medications, but also being able to access a pharmacist is important.
Anyone else? Thank you, Lauren, very much. I
you.
appreciate it.
Thank you, Lauren.
I think we're gonna shake things up a little bit, and Thea, we're gonna go to you next. That's okay. Welcome.
Thank you so much. My name is Theo Kennedy. I'm an attorney in private practice. I'm also a public policy attorney, AKA lobbyist for the Vermont Pharmacists Association and for Rutland Pharmacy. It used to be the retail druggist. I sent, my comments are going to be brief. I might wrap around. Jeff should have come up. Lauren Bodie and Jeff are representatives of my two clients. And I sent a document that I'm just going to quickly reference for the committee because it helps kind of frame what I'd like to briefly go over with you. There, I pulled it up. So first, I want to thank the committee. It's an honor, privilege, and a pleasure always to have an opportunity to speak to you. And we think H233 is a great piece of work. Is it complicated? Yeah. Are there a number of moving pieces? Yeah. Are there some internal inconsistencies? Yeah. But what we hope to do is be able to look at it with you, be a resource for you should you have any questions, at least from the pharmacies and pharmacists perspective. And we urge its passage. So just briefly in the outline that I submitted, and thanks to Jen for doing that crosswalk, we kind of did that behind the scenes as well, because ferreting out what's new and what's not matters, particularly as you're considering what you want to pass into law. So the first section, if folks have it up, that I address is enforcement of present law. And I'm not going to read all the remarks, but you can see their A through F are areas of existing law that thanks to you and this body, we have in statute. And issues of enforcement, adherence, compliance takes time. And so that's not really what we're asking you. You're going to help us draft laws, and hopefully the executive branch and other parts of the executive branch are going to help us enforce them. But so we don't really have an ask other than a thank you for passing those areas and making a difference, we hope, for community pharmacy. in the second section, I just kind of broke this up into, if there is such a thing with this bill, bite-sized pieces. So one of them is the licensure model. And that is, as I understand it, is substantially based on the National Association of Insurance Commissioners Model Act. And we support it. And we thank DFR, if they're properly resourced, for their interest in taking on this role. We view it as a step long overdue. We think it'll give greater authority about jurisdiction in this area. And so I think that's it. Again, you can read my specific words if you so choose. I'm not going to read my testimony. I just wanted to have it as a leave behind. We're not going to talk about wholesale acquisition today. I think, may talk about something or a study on Thursday or later in the week. So I'm simply going to jump over that. Okay. In each instance, I've given some resources that tether you back to work that you've done in the past. So in the first area around enforcement, I put a link to the Act 131 report, which you already know, because I think it's a very good resource. In the wholesale acquisition, which I'm not going to talk about, I give a resource to the Act 193 report that DEVA did, which kind of is the closest, most recent work, albeit in 2018, that was done to look at that concept. A couple other things in here that we support. We support a spread pricing ban. You know, when you get a chance to hear from Medicaid and how they're set up, we think it's a best practice, a pharmacy benefit administrator. They don't have them involved in the buying and selling part of it. And there's a pass-through. Again, they need to speak for themselves. There's a pass-through methodology. And they have a basis for reimbursing pharmacists, which we think is, well, it's a CMS methodology and it's excellent in its ingredients. But actually, I'm jumping ahead of myself. So let me stick with the spread pricing ban. So we do support a spread pricing ban. We understand that testimony could make this a heavy lift. And we don't want to see the current system exacerbate prices to consumers or premiums to consumers. So how you unbundle this over time is yours to choose. But if you were to not pass a ban on spread pricing, we'd ask that the law be fleshed out a little bit more than the aggregate disclosure that you heard Jen recite. And I put some specific language there because what we're really looking for is to understand, or at least the pharmacies and the pharmacists would like you to know what's actually happening on the ground each day for every prescription. Because that is known. It's just not known by all the parties in the system. So if you don't ban spread pricing, we kind of would hope you would get at the specific data on a prescription level. Also,
Can you hold 1 second? We have a question.
oh, yeah, sure.
You know, I don't know what
Mhm.
spread pricing ban means.
Okay, so again,
Do you
I
know?
want to defer. I'll tell you what I use in my head for this. I try to go as in terms of the simplest constituent elements, but I also want to respect that there are other folks with expertise that you've heard from that are presently in government positions of authority to tell you. But essentially, what you want to think about it is that the PBM pays the pharmacist X, okay, and for that same X, it gets something from the insurer of value. There's a delta between what it gets the insurer and what it pays the pharmacist. There's an aggregate delta and there's a micro delta. That micro delta is happening every second, every day, every script across the country, but in Vermont. And so the spread is the difference between what the insurer is getting paid through its agent, the PBM. So that you're going to have to unbundle that with insurers, but the PBM uniquely knows about it's getting paid in its contract with the insurer, and then it's going over and paying a pharmacist. And that price is not the same. Now, is there necessarily something grandly nefarious and conspiratorial about this? No. It's business, right? This is the business side of healthcare. So the question is, how much of that profit do we as Vermonters want to make sure goes into to save money for our system, right? Not just about tax revenues, but particularly to our system. So right now, it's not really understood whether the aggregate numbers that the insurer use for premiums on the pharmacy side of the book, which go up year after year, need to be as high as they are. And again, Sebastian and others can tell you the statutory standard is roughly for premiums neither deficient nor excessive nor unfairly discriminatory. I think there's reasonable basis to believe that we don't know whether they're excessive. And in fact, we think that once the data begins to be revealed, we'll find that it often is. Now, can PBMs live without spread pricing? They're going to have to come and testify to you about that and how their rebates work. if you use rebates, that's part of where they get their profit. Again, profit in of itself is not a bad thing. The question is of whether it's excessive and whether it's more than the system should have to pay. So the short answer was the delta between what the PBM gets from the insurer and what it pays the pharmacist.
We're gonna hear a lot more.
And others will correct me. And my goal is to be as accurate as possible.
Maureen?
So to be clear on a couple of things, the amount that the PBM pays the pharmacist is an amount on a prescription by prescription basis is an amount that only the PBM and the pharmacist know. The insurer doesn't know what the PBM paid the pharmacist, and in certain cases, I'll let others say whether it's often or not. It's definitely less than the insurance. And then the other thing is that spread pricing is something that has hurt independent pharmacies or Vermont community pharmacies. Would you say that that's accurate?
Yeah, so thank you, Mari, and thank you on behalf of the pharmacies and pharmacists for your leadership in this area. There are two things and then the last one, right? And I want to make sure. So as far as knowledge, the system is set up, in fact, they're kind of pods of knowledge, right? So the answer is no. The insurer doesn't know what the pharmacist is being paid. Under laws which you've passed, and Jen helped us remember, some of them are pretty recently, that are available, pharmacists can now share some of that data. So most of that data, we want to do it very carefully, but nonetheless, so that folks can know. So the insurers have audit capacity, so they can go to a specific script at a specific time. So again, they're going to speak for themselves, but in order to know whether the system is working well for Vermonters, in theory, if not practice, you'd have to audit every claim, right? And that's not what's currently been done. So the answer to the first one is what they know, they don't know that price, and vice versa, by the way, that pharmacists aren't privy to the negotiations with the insurers. As to the issue of under acquisition costs, I think is what you were talking about. That does happen. It doesn't happen all the time, but it does happen. And some recent law that you passed, which think needs a little tweak, because when we make new laws, the regulated bodies try to comply with it and then sometimes find creative ways to continue types of practices. And you allowed us, and I'm speaking on behalf of my client, to appeal when they get a payment that's less than what they acquired the drug for. And then there's a process that's now in law which asks that in that appeal process that an available product be identified that the pharmacist could have purchased, so that there's a legitimate defense, as it were, that they're getting under reimbursed because they could have gotten it for a lesser price. That bit of the law is still unfolding, and we're still finding out. That could go a long way to, if it were properly enforced and overseen, to helping community pharmacies in the way that you're addressing. Because I think we heard in testimony, this bill, as important it is, and we support it, the pieces that are left aren't linearly directly helping a community pharmacy stay afloat today, right? It's helping the regulatory body get a handle on it, and we think that's very important, and we want to cooperate in providing all the data possible. And then the last one was about whether it hurt or didn't hurt spread pricing aggregate as an aggregate, and I'm going to punt that, not because I don't have an answer in mind, but I'm going to punt that to my client, Jeff, to talk a little bit about that. The short story is it depends how it's done and where do the rebates go and what portion of the rebates are kept by which party in the stream. So what we're asking for is a much simpler approach. And that leads me back, I think, to my comments. I think I skirted your third question a little bit because I'm going to punt to Jeff. Hopefully, I don't want to waste the committee's time, and I know others are here to speak. So, so generally, the spread pricing ban is something we'd love to explore with you and learn more about. How does it manifest? And does it hurt pharmacists? The one important thing to remember, at least from our perspective, is so long as the pharmacist, again, that wants to be practicing at the top of their clinical license is reimburse what they acquire the drug for and some reasonable professional fee. That's all that we would ever ask for. So a system which provides for a benchmark like that leads me into this last area. And this kind of, we say acquisition cost plus here, but this is the dispensing fee part of the bill. And I think I've given specific section references to the bill as introduced. I would say here that we don't want more than fair remuneration. And we think that the system as currently built is probably not as simple as it could be. And that so long as there's a methodology, if you think about the methodology as separate from the outcome. So I think the Medicaid dispensing fee now is somewhere in the middle of the country in its range. But the underlying methodology is, I think it's initially in statute, but it's detailed in code and federal regulation. And it's an excellent system. So I think later, maybe we'll give a link, but if you want to look at that methodology, or maybe it'll be Medicaid who would be best positioned to tell you what methodology they use. But it gets at a way of evaluating ingredient costs, active and inactive, the cost of doing business. There are a number of different pieces that kind of are economic model for getting at a valid dispensing fee that we endorse and is already in federal law. So I think that's the outline. I'm going to skip over copay accumulator because we're so happy that Healthcare Advocate is going to discuss that with you, and we support that as well. And I'm going to pass it to Jeff. And
Actually, we're going to not go to Jeff.
we'll not go to Jeff.
So any questions for Theo?
I have 100 questions.
I know. We're going to do this every afternoon this week. So.
Right. I'll pass.
Sure.
Yeah, absolutely. Thank you.
Well, in closing, we support the bill and we want to be available to help you in any way we can on behalf of the pharmacies and the pharmacists.
Thank you, Theo.
Thank you very much.
Thanks, Theo.
We are actually going to go to Charlie. It's Charlie, right? It's not Charles. Charles. Sorry, Charles.
I'll introduce myself as Charles, but everyone calls me Charlie,
Okay,
so
great.
you can call me Charlie. Thank you very much for having me. Let me just get situated here. So I'm going to start with some introductory remarks and then get to a slide presentation. So yeah, get up here. All right.
Anytime.
So thank you very much for having me. Again, for the record, my name is Charles Becker. Everyone calls me Charlie Becker, staff attorney with the Office of the Healthcare Advocate. Since this is my first time coming before you all, I'll just tell you a little bit about myself. I've been with the HCA now for 2 years. And then before that, I was a staff attorney at the Disability Law Project of Vermont Legal Aid for 6 years. And then before that, before law school, I was a textbook editor, at middle school and high school, social studies textbooks
I know
for
that.
close to 10 years. Yeah. So I do not have a health policy background. So you have, why am I here?
Why are we all here?
What I do have is a background as a consumer of healthcare services, and specifically my experiences as a person with high annual pharmacy claims. That's been the case for most of my adult life and will be probably the case for the rest of my life. For me, pharmaceuticals have literally been a lifesaver, but they're expensive. And when you need an expensive medication, you really become acutely aware of how dependent you are on a highly functioning healthcare system. There's a certain amount of stress you carry with you all the time. What if I somehow lose access to my treatment? Passage of the Affordable Care Act was a huge relief and gave me the courage to leave a stable job as a textbook editor and go to law school. But lately, things have taken a turn for the worse, I would say. Quickly, I want to share a story with you about a time recently when my access to medication was jeopardized. And that happened to me, as I said, recently, with good healthcare coverage that I have through my partner's employer. For the 2022 plan year, I was required to use a specialty drug mail order pharmacy operated by my health plan's PBM. It was not a good experience. A few weeks before the plan year started, I received a letter informing me that coupons would no longer count towards my deductibles or out-of-pocket maximum access when the words copay accumulator adjustment program first entered my life. Suffice it, I'm going to come back to that topic later, but suffice it to say, things went downhill from there. Despite me telling the pharmacy to remove the copay assistance from my account, if the coupon wasn't going to count, I wasn't going to use it. I told them remove the coupon from my account. They went ahead and used it anyway. At the same time, they took payments from me, totaling my full out-of-pocket maximum for the year. Except I kept noticing balances on my account month to month when I went to fill my prescriptions. And by June, the PBM pharmacy was insisting I owed them a couple of $1,000s. I requested an accounting, which showed that they'd gone ahead and used that copay assistance, and now they were insisting that I had to pay them back for it. This is after I told them not to use the coupon, and after I had made payments out of my own pocket, totaling my out-of-pocket tax for the year. I spent many, many hours on the phone with them trying to get them to fix the problem. Eventually, in August of that year, they just refused to send me my medication. Literally, if I would not pay them the money I did not owe them, they would not send me my medication. So I paid cash that month at a local chain pharmacy, but I told my partner it was time to go to their HR department and get them to straighten this out. And really, who wants to do that? Go to your HR and say, I know we cost you a lot of money every year, but here's a problem that's going on and we need you to fix it. Well, fortunately, my partner has a good employer and they fixed the problem. So I get into my presentation here. But that was, a true story of something that happened to me. Oh, here we go. And so I tell that story not to be dramatic, but to make the point that regulation of PBMs is a consumer protection issue. This isn't just a matter of saving our community pharmacies, though it is that, and that's an important goal. It's a consumer protection issue too. When I was going through that ordeal with the PBM pharmacy, and I want to stress it was an ordeal that took me months to sort through, that really, really elevated my levels of stress and left me feeling powerless and beholden to an entity that I knew did not care about me, no matter what their marketing materials said. When I was going through all of that, I spent a lot of time in online consumer forums, just trying to get a sense of, am I the only one going through this? And it was very little comfort to learn that, no, I was not alone. There are many, many other people that are being harmed by PBMs. And I'm not saying that that harm is intentional, but it's happening. And it's at the very least negligent, and it's still harm that people are experiencing. So Act 131 was a major step forward, I want to say. I think there's a tendency of some people to think that Act 131 was about PBM relations with pharmacies and health plans, but there were significant consumer protections in Act 131 too. Specifically, Act 131 eliminated specialty pharmacy networks by requiring that PBMs allow retail pharmacies to fill all prescriptions, regardless of whether the drug is considered to be specialty by the PBM. Act 131 prohibited mandatory mail order pharmacy and other PBM patient steering mechanisms where they try to get you to use their pharmacy. Act 131 restricted mid-year formulary changes. It instituted consumer cost protections by limiting the amount a PBM can require a covered person to pay for drugs to no more than the cost sharing under the plan, the maximum allowable cost at MAC price, or the cash price, whichever is less. And it, I say here, impliedly banned copay accumulator adjustment programs. And I put a question mark there. And I'm going to come back to that a little bit later. All of this was great. Act 131 was a major step forward, except that it lacked an enforcement mechanism, which is why the HCA is eager for you to take up PBM regulation again here with H233. H233 builds upon Act 131. And at the outset, I want to say that the HCA supports H233. As this committee goes through the legislation, I'm sure there's going to be parts of it that we're not going to agree with fully, but we do agree with the basic framework that's outlined here in H233. As I said, it incorporates all of Act 131's consumer protection provisions, plus does more. It requires PBMs to be licensed with the state and provides DFR enforcement rights, right? And it includes potentially fining PBMs up to $50,000 for violations of the law. I think it also allows DFR to withdraw the right of a PBM to operate in the state if they're not complying with the law. It allows for a private right of action for pharmacies, pharmacists, or others aggrieved by PBMs, which to me means you can sue. If you're aggrieved by the PBM, you can sue. That's important. It allows the HCA access to PBM data collected during their own enforcement proceedings, which would provide for consumer-focused oversight outside of government, which I think is something that's important. So just quickly, we support all of those provisions of the bill, but there are additional things that I wanted to talk to you about. 3 specific provisions that I want to talk about in a little bit more depth. Before I do that, though, I just want to say, throughout the week, you are going to hear from many, many experts that are going to be better suited than me to speak to some of the technical aspects of these provisions. I'm going to do my best to present a consumer advocate lens to these. And if you have any questions, by all means, ask me. But I'm going to try to not overstep my knowledge on these issues. And if I don't know an answer, I'm simply going to let you know I don't know. And also in this presentation, I'm going to make some factual claims. You might be thinking to yourself, well, why is he speaking with such authority? Where did he get this from? In my written testimony, which I submitted to the committee, I provided citations and such. So if you want to follow through on some of what I say here today, you can do so through my written testimony. So the first provision I'd like to discuss is the reimbursement of pharmacies at actual acquisition cost plus a dispensing fee. It's on page 22 of the bill. You all have it in your printouts there, but the important language there is that the reimbursement amount up to pharmacy shall be calculated on a per unit basis based on the pharmacy's actual acquisition cost and shall include a professional dispensing fee. HCA supports reimbursing pharmacies at their actual acquisition cost plus a dispensing fee. And I should say, in principle, we support this, right? So that's an important thing. And I think my Mr. Fisher would be happy for me to get that out there. In principle, we support this. It just makes sense. If one goal of H233 is to make the system more transparent, then reimbursing pharmacies at their actual acquisition cost plus a fee is a step in the right direction. Last summer, I had good fortune to come across this report online, Unraveling the Drug Pricing Blanket by trusted experts. You've probably heard their names already, 3Axis Advisors. If you haven't read this report, I highly suggest you do. It's excellent. I provide a snippet here of some of the language. Our study found the greatest harm from our current system's approach to drug pricing appears to be on patients. And what they found in their report, if you read the report, is that in our current system, PBMs control the reimbursement to pharmacies. They set the amount that the pharmacies are going to be reimbursed. And it's not uncommon for a pharmacy to be reimbursed many different prices for the same drug, sometimes even on the same day. Sometimes higher than the pharmacy's costs, sometimes lower than the pharmacy's costs. They go on to say, while these disparate pricing experiences can have a significant impact on pharmacy providers and health sponsors, the most obvious and important impact is felt by the patient. So again, that's why reimbursing pharmacies at their actual acquisition cost plus professional fee would make drug pricing more rational and transparent. In practice, though, we need to have clarity on what that actual acquisition cost is. And there is a benchmark out there. It's called NADAC. It's another acronym for you all, the National Average Drug Acquisition Cost. And NADAC is considered to be, 2 things about this. It's publicly available. You can go online right now, and for any prescription you're taking, most prescriptions you're taking, you can find what the NADAC price is. And it is understood in the industry to be a reliable indicator of pharmacies' actual acquisition costs. The state of West Virginia already requires that pharmacies be reimbursed at NADAC plus a dispensing fee. And my sense from a very brief phone call to their insurance regulator is that this is working out fairly well for them. They're not having a bad experience with it. But, and this is the caveat of why we conditionally support this, to ensure that patients benefit, or at least held harmless, we propose adding language to section 3612E of this bill. I'm top of page 11, this is the provision from Act 131 that says PBMs cannot require consumers to pay more than their cost sharing, the maximum allowable cost of a cash price. We think we should add to that list the actual acquisition cost plus a dispensing fee. And again,
Sorry, where are we? Where are
at the
you?
top of page 11
Of the bill or of your presentation?
of the bill.
Okay,
Yep.
if you could repeat.
Yes, absolutely. Yeah. So there should be 3612E on page 11, hopefully if I did this right.
Hold on, give us a second. 36, 12.
It's at the very bottom of the page before, so the content we're talking about is.
Thank you.
Okay, so E1 on page 10 that
So
goes
there's a
over.
list here of saying that the PBM cannot require a beneficiary to pay any more than the greater than the lesser than the actual cost sharing under the plan, the maximum allowable cost of the cash price, whichever is less. We think you should add to this list actual acquisition costs plus a dispensing fee.
And you're doing this because this would be what the patient would pay.
If it's less than any of those other prices available to the consumer, yes. The lesser of those three, and we would suggest 4, is what the consumer should pay.
Consumer should pay.
So the NADAC actual acquisition cost, or based on NADAC, and dispensing fees are the same thing as what Theo was referring to as professional.
And I maybe got a step ahead of where we are as a group. I'm saying NADAC is a way for us to potentially gauge actual acquisition costs plus a dispensing fee. That NADAC is one benchmark that's available that represents the actual acquisition costs fairly closely.
I just want to be clear, dispensing fee is interchangeable with professional fees.
Yes,
Having
yes, absolutely, yeah, yep. So that's the actual acquisition cost plus dispensing fee issue. Is everyone still with me?
Yes, we
Okay.
are.
All right, the next issue I wanted to talk about was the rebate pass-through language here. That's also on page 11 of the bill, section 3612E2. The bill says that the patient's cost sharing shall be calculated at point of sale based on a price that has been reduced to an amount equal to 100% of all rebates received or to be received, and that any remaining rebate in excess of the covered person's cost sharing be passed on to the health plan to reduce premiums. Said simply, this provision would require that all state-regulated plans in Vermont, health plans in Vermont, become full rebate pass-through plans with an important distinction. And that's that ordinarily the concept of full rebate pass-through suggests that the rebate is passing from the PBM to the health plan in full. What this would do is it says that first, the rebate needs to be applied to the patient's cost sharing, and then any additional amount of rebate can go to the health plan in full to reduce premiums. We support this language because frankly, patients who are generating rebates for health plans should directly benefit from the rebate. Right now, that is not the case. Currently, when a prescribed medication, when a patient is prescribed the medication, imagine it's one of these expensive brand name medications, in the deductible phase of the year, when that person has basically no coverage, they have to meet the deductible first. That person will go to the pharmacy counter and pay the full list price for the drug. And mind you, that's a full inflated list price because the rebate that the PBM negotiated has the effect of driving up drug prices.
I'm sorry for interrupting your,
No, please.
but I think we need a definition of what a rebate is.
Okay.
Give an example if you can. If not, we can look to someone else in the room.
Well, I am gonna go through an example. I'm actually gonna to go through DFR's example from last week. But a rebate is money that a drug manufacturer pays to a pharmacy benefit manager that sometimes gets passed through to a health plan to, as I believe was said last week, to obtain access to the PBM's formulary.
Does everyone understand that?
So one more time.
It's a payment from a drug manufacturer to, it's a To gain access to the PBM's formulary. Yeah, is what it is.
Right. So a manufacturer produces drug Z and pays the PBM a rebate for the privilege of having the PBM put drug Z in the list of medications that's on the formulary that the insurer,
That's exactly right.
okay.
In the context of pharmaceutical distribution, that's what we mean, but when we say a rebate. And so here's the example that DFR showed you last week. And I believe DFR presented this example to illustrate the point that rebating increases the cost to the system of brand name drugs. Here you can see that there's a drug with a $100 list price for which the manufacturer pays a $20 rebate to the PBM to get placement on their formulary. Meaning they're charging $100 for the drug, but they're willing to take $80 for it. They're gonna give 20 to the PBM in order to get access to that formulary. So I want to be clear here that this is not DFR's example. They pulled this example from University of Southern California Schaefer Center letter to the Federal Trade Commission. And as I just explained, it shows how a $100 drug with a $20 rebate, the system ends up paying $107.14 for that drug, for the drug that the manufacturer is willing to accept $80 for. And so, to be clear, we agree, the HCA agrees with this concept that rebates, the practice of rebating the price of drugs leads to higher drug prices. And in fact, the same University of Southern California Schaefer Center concluded that for every dollar of rebate, the price of a drug goes up by $1.17. A dollar of rebate, the drug price goes up $1.17. So the practice of rebating is driving up the cost of drugs. And here's, from a consumer's perspective, though, there are a few problems with this example, and at least with respect to how patients experience rebates in the deductible phase. So the problem with this example is that in the deductible phase, unless this was for a drug for which the deductible was waived, and that's just a small number of drugs, then the patient wouldn't pay $20, which is listed here when they go to the pharmacy counter. They pay at least $100. The full list price of the drug, and they might even pay more. So I went ahead and marked up this example to show from a consumer's perspective what this might look like. First, the drug's list price was listed at $100, and we heard that the list price of $100 is the WAC price, the wholesale acquisition cost price. And that's right, but there are actually two list prices. There's the wholesale acquisition cost price, and there's also the AWP, the average wholesale price. And the AWP is an additional inflated number. Think of it as the price you see when you go to a car lot and look to buy a brand new car. It's an additional markup over the list price that gives people room for negotiation, right? It's a negotiating point. And it's understood in the industry that AWP is about 20% higher than the WAC price, which is why up here I said that the AWP price for this drug would be $120. As for the pharmacy's acquisition costs, we said we support, giving pharmacies their acquisition costs. We know because we have NADAC, the National Average Drug Acquisition Cost, that pharmacies are actually acquiring brand name drugs at about 4% off of WAC. So that's why here I put $96 as the price that the pharmacy acquired this drug at. Next, we know that PBMs typically negotiate their contracts with their pharmacies and their health plans. So they're negotiating contracts with pharmacies to negotiate reimbursement. And they have contracts with their health plans to dictate how much they're going to get reimbursed from their health plans for drugs too. So those negotiations take place off of the average wholesale price, AWP. So in this example, the health plan negotiated a 15% discount off of AWP, which is pretty typical. And that's why when the patient goes to the pharmacy counter during their deductible phase, what they pay is $102 for this drug, a 15% discount off of AWP. But even with that discount, you can see that the patient paid $2 more than the WAC price and more than anyone else in this example is paying for this drug. In fact, if we look here, the only one that's paying for this drug in this example is the patient. And that doesn't even take into account premiums. So the patient is also paying premiums every month for the benefit, at least during the deductible phase, of not having any coverage. And the example, I'm not sure where they got this figure from, they gave was $87.14. Well, the cheapest bronze plans in Vermont are $750 a month. So I put $500 a month here as being something reasonable, that maybe the person has a subsidy on the exchange, or they have an employer-sponsored plan where maybe it's a reasonable amount that people are probably paying each month for health insurance. And so the last point I want to make about this is with the $1,600 out-of-pocket max, which is the Vermont out-of-pocket max limit for prescription drugs, this person with a $100 a month drug could go to the pharmacy every month, pay $102 for their drug, while the PBM and the health plan split a $20 rebate every month. This person can go every month and never get coverage for this drug, but pay the full $102 every month because they're never going to hit the $1,600 out-of-pocket maximum. So this is just, I bring this up just to say that, yes, the HCA supports the concept of rebate pass-through. We think patients should be getting the benefit of rebates. And that's that. I anticipate hearing that you're going to hear testimony later this week that the effective rebate pass-through at point of sale would be to drive up premiums. Just quickly, I want to say why I think that's overstated. Remember that the rebate in this example would only pass through to the patient at point of sale if they actually had cost sharing under the plan. And we also know that the state of Vermont has a $1,600 out-of-pocket max each year. So the maximum amount of rebate pass-through to a patient would be $1,600. And we're talking here about very expensive brand name drugs, right? Drugs that might cost $10,000 a year, $50,000 a year, $100,000 a year. Those are realistic figures, right? That's what some of these drugs cost. The ones that are driving rebates, the health plan is going to retain the vast majority of the rebate in all of those circumstances, even after passing it through to a consumer at point of sale. So I'm about to pivot to my last topic.
Yeah, let's stop there for a second.
Okay.
I'm thoroughly confused.
Yeah.
I'm so glad.
And not because of you, really, it's just
Yeah,
so.
because of you.
Yeah.
It's absurd.
It's confusing.
Mhm.
So just want to sit here for a moment.
And maybe in this moment I can get a sip of water.
Yes, please do.
Okay.
So if all the rebate is going to go to the patient, what their cost share is, whatever left over, it's going to go to the insurer. Where's the incentive for the PBM to do any rebates whatsoever? And is that a good thing or a bad thing?
That's a great question, and I don't have the answer to that. I mean, I think people would say that PBMs then wouldn't have an incentive to negotiate for rebates, but I think I would say to that, we see here rebates are driving up prices. So maybe we want to slowly wean ourselves from the system of having rebates. I mean, I don't think H233 accomplishes that, but I think getting the patients to benefit from the rebate is a step in the right direction. And personally, I mean, the rebating, it's driving up our drug prices. So we need to try to move away from it. That's my take on that.
Art?
Yeah, who sets the rebate price? How, it almost seems like a bidding war.
I think that would be fair to say. I mean, it's a negotiation between the manufacturer and the PBM.
So they could all be different. The amount of rebate, could it all be different between manufacturers? I don't know how many manufacturers there are.
I would, let me ask it this way. the manufacturer, I think the PBM, so there's multiple PBMs. So you're talking about one drug, right? Correct me if I'm wrong.
Okay,
Anyone in the
right,
room?
right,
One drug from a manufacturer, let's just say aspirin.
yeah.
But there might be multiple PBMs negotiating with that manufacturer on aspirin, and they could each have a different rebate.
They could
Is that
even-
accurate?
Sounds right to me.
Okay.
Okay, and it could be multiple aspirin manufacturers.
Could be, I guess.
So I mean,
Especially in the generic world, like
Yeah.
lisinopril. you
Well,
know,
that's,
blood pressure
I should be careful about that. With the multiple manufacturers, that's not where rebating is happening, right? Like rebating is not happening on the generic drugs, or if it is, it's happening on a very minimal scale. Rebating is happening on the most expensive brand name drugs for which there's no generic competition. There might be competition from other manufacturers in the same therapeutic class, and that's where you might get into a bidding war between manufacturers of drugs within the same therapeutic class.
And we're gonna hear from a lot of other people on the same topic, so we keep our questions in mind as we talk to new people. Melanie and then Mari.
And in the current system, the rebates are really only helping benefiting the health plan.
I think under the current system, the rebates are helping both the PBMs and the health plans.
But not the patient directly.
Well, not the patient directly, right?
Only theoretically by keeping the premiums lower.
That's exactly
That's the
right.
argument.
That's exactly right.
But when we look at something like you with red,
Mhm.
it's questionable.
Yeah,
One second, Mari, and then Art.
The pharmaceutical world, and all the entities that are involved in getting the medication from the manufacturer to the patient, I don't believe is competitive. It's not like in terms of true capitalism, it's not a competitive market. And that's why the FTC has been over the last few years, taking a serious look at who's controlling the market. And in recent testimony at the federal level, a certain someone said the PBMs, the government is not controlling pharmaceutical costs, the PBMs are, and they may disagree with that. But would you say that the rebates are another tool in the steering bucket of how PBMs make money and potentially manufacturers by creating incentives to steer towards that specific brand name medication?
well, yes, I do. I
Or
mean,
another.
you already heard testimony about the formulary tiers and how some products earn preferred placement on a lower or cheaper tier and others are on a more expensive tier. I mean, that is how rebates, when the PBM gets that bigger rebate from manufacturer X, they put that manufacturer's drug on the preferred tier, right? And that makes it cheaper for patients. Whether or not that means that the patient actually gets steered to that drug is another matter. And I think it's actually a nice way to pivot to talking about copay accumulator adjustment programs, which is my favorite topic. Okay, one.
Sorry, we have a question. We're trying. Art
yeah,
or Alyssa?
okay, so the rebate gets the drug on the formulary of some expensive type of drug.
Mhm.
So who then accesses the formulary? The pharmacist? Does the pharmacist now go in and say, I need drug ABC, and all the ABC formularies come up and I pick one, or?
No.
Yeah.
So it's the patient when they're at the doctor's office and they're being prescribed a medication for a condition,
Yeah.
rheumatoid arthritis.
Sure.
And the doctor says, here are your options, right? A savvy consumer is going to check their plan's formulary and find out which one is on the lowest tier. It's going to be if they're concerned about money, and I shouldn't use words like savvy consumer, right? Like
Yeah.
if they're concerned
I
about
understand.
saving money, they would do that.
Okay, so the formulary puts, the rebate puts the money on the formulary that now everyone can see?
No, the consumer's not going to see that the PBM, the consumer can intuit that the PBM received a rebate, but they're not going to know what the rebate.
Who does know? Who knows what drugs are on the formulary?
You can look at your plan right now.
Oh, all
and
right,
yeah,
okay.
I
yeah.
just don't know what the rebate is.
You just don't know what the.
No, I don't care about the
Yep.
rebate. I just want to get the process from the rebate to the formulary to who.
You know, in fact, though, it's an interesting question. Like, it used to be that you could log into your plan's website and literally download the formulary. Now you go to the plan website and you have to enter a specific drug name. You can't just, I can't find it anymore, like the actual full formulary. Which seems annoying to me. I want to look at the full thing.
But where does your doctor come in? I mean,
Well, you have to have a conversation as a patient with your doctor, like, this one's on the higher tier. I can't afford it, doctor.
okay.
You know, yeah.
There's tier 1, 2, 3, right, Alyssa?
Yeah, and they literally, when they're prescribing you, they're plunking in what your insurance's formulary is and looking at saying.
Okay. I've never known that. Okay.
I don't know if this question's been answered yet or not, but I remember a while back where the doctors did play a big role in what drugs would get on the formulary.
Mhm.
And they were compensated for that. Yeah, are they completely out of the picture now altogether?
I do not know the answer to that question. I suspect it's probably happened, but I don't know.
Well,
Mark that, 'cause we might have someone else that could answer that.
Okay.
Over the next couple days. Alyssa.
So I'm just thinking, like, to continue on your previous conversation. So let's face it, a PBM makes their money by spread pricing, rebates, administrative fees. That's where they're getting their money from.
Correct.
So if a manufacturer has a drug that they want preferred on a formulary, they're going to offer rebates, and it's probably going to be one of their more expensive drugs. Which means, has there been studies where they've like looked at formularies and they've said, you know, the WAC price on tier 3 is actually lower than on tier 1? Basically, are we steering people to the higher price drugs? And yes, the PBM is going to make money. Wholesaler is going to make money, or the manufacturer is going to make money. But not only is the patient probably will pay less, because if they're on that tier, they'll have a lower cost share, maybe, unless they have a deductible. But the insurance is actually going to be paying the highest price.
Well, and that's why I think we see such high annual pharmacy cost trend during rate review time. That's why we see our rates going up so high is it's because the practice of rebating is driving up the cost of drugs, and it's driving up everyone's premiums at the same time. I mean, are there studies? Yeah, I'm sure there are plenty of studies. and I'm not prepared here to tell you what they are, and maybe I could follow up with you, right? But there's been lots studied and written about this concept, right? But yeah, I mean, I think the rebating is driving people on some level to drugs that are expensive, and it is, and in the end, you know, driving up premiums.
Driving up premiums, driving up out-of-pocket costs for patients.
Mhm.
And the only one making bank is PBMs
and
and the manufacturer.
So I
Maybe.
just want to, I should have said this when we started. I want to make sure that we are using very respectful language as we talk through this process and all of the players. So I just want to be very clear. I will stop the conversation if we're not doing that. No offense to
Yeah.
you, but
I should have said making profit.
making profits. Yes, thank you. Okay.
Okay.
Let's go to the
So
next.
I've taken up a lot of time.
No, you're good. You're great.
So let me pivot to my last topic, a copay accumulator adjustment programs. H233 would affirmatively ban copay accumulator adjustment programs in Vermont, and we support this change. I'm going to kind of go through this topic quickly. I gave a presentation last week in Senate Health and Welfare about copay accumulator adjustment programs. So we have someone from the Arthritis Foundation lined up to speak to you too about this issue. So I'm going to go through this quickly. First, what is a copay accumulator adjustment program? You heard me talk about at the beginning of my presentation, that letter I got from the PBM, my PBM saying coupons aren't going to count anymore. This is that letter. And it says here, you can see in the top box, this, that the coupons will no longer count toward your deductible and out-of-pocket maximum. And then why is this called a copay accumulator adjustment? So in the bottom box, that's where all the details are. They say at first the copay assistance will appear to count, right? So within the first 2 days, a couple of days of having that claim processed, the value of the copay assistance is going to appear in your copay accumulator. It's going to make it look like you're that much closer to meeting your deductible or out-of-pocket maximum. But then within a few days, they subtract that copay assistance back out of your accumulator. And that's the adjustment. They subtract the value of the manufacturer's copay assistance from your accumulator, erasing any benefit to the patient, but notably reducing the insurer's costs. I'm not going to go through this example. It's in my slides, but you can see here that in the bottom example, John had a copay card, but his plan had an accumulator policy. And that meant that the $1,200 value of that copay assistance was taken from him and given to the health insurance plan, therefore reducing the health insurance plan's exposure to the cost of that drug. And the patient didn't get any benefit. So what is the status of copay accumulators under current Vermont law? We are not one of the 19 states, those are the ones shaded blue here, that have affirmative copay accumulator bans on the books. What we have is language from Act 131. We've heard it a couple of times here already, that any amounts paid by a covered person must count toward any deductible and out-of-pocket maximum. In DFR's Act 131 report, they said, quote, read in a light most favorable to patients, the statutory language suggests that Vermont health plans must apply copayment assistance to patient deductibles, end quote. That's why I say I think we have an implied ban. I don't know. But since in the light most favorable to patients isn't a legal standard, and it's not really how courts and regulators frequently interpret the law, I think from a patient's perspective, it would be far better to affirmatively ban copay accumulators, to make it clear that any amounts paid by or on behalf of, that's the key language here, must be applied to any deductible or out-of-pocket maximum, and that includes any third-party payments, financial assistance, discounts, coupons, etc. This is the language from H233. I tell you where you can find it in your printouts, and just that it amends 2 sections of current Vermont statute that were passed with Act 131. We strongly support this language, and I really want to briefly say why. First, to the point that for patients, these things, so what are these things? These copay assistance cards, right? This is what they look like. A lot of the times these days they're digital, you get it on your phone, right? This is what we're talking about here. That these things are great for patients because you get access to an expensive brand name drug. And because Vermont has that low $1,600 out-of-pocket max, before you know it, you've hit your limit, and then you don't have to worry about it anymore. To that point, which I think we heard in testimony last week, I would say, yes, absolutely. That's exactly the point. Copay assistance enables patients to access expensive, but in many cases, life-saving or at least life-improving medications so that they don't have to worry about it anymore, at least until next January. And that's a very important thing. So that's one reason why we support a copay accumulator ban. Another point that was made last week, and again, this was, from the perspective of a health plan or from a PBM, is that with a coupon, patients are steered towards more expensive brand medications instead of potentially taking a cheaper generic. I don't think the data that's available out there on this topic suggests that that's true. I think what you would see is that the vast majority of copay assistance is being utilized when there is no generic equivalent available. And that furthermore, when generics do enter the market, that copay assistance begins to taper off. I'm not quite ready for that yet. It was also stated that from a health plan's point of view, that issuing coupons is what manufacturers do when they don't get that preferred placement on the formulary, and that it gives them a way to circumvent or undermine a PBM's formulary. I don't think that's quite right either. First, pretty much all of these brand name drugs have copay assistance, particularly where there are multiple brands competing in a single therapeutic class without generic competition. They're all competing for business. They want to get on the formulary and they want to get patients. They all have coupons. So it's just as likely that a drug with preferred placement on the formulary has a coupon as it is that a drug without non-preferred drug has a drug coupon. Also, first of all, and the drug is on the formulary. It's literally on the formulary. If the drug is not on the formulary, that means the patient doesn't have coverage and they can't use the coupon. You can only use a coupon if the drug is on the PBM's formulary. And lastly, any utilization management that the PBM has in place, step therapy requirements, prior authorization requirements, all of that remains. A drug manufacturer's copay assistance card does not circumvent any of that, and I would say it does not undermine formularies. Remember that all that preferred and non-preferred means is that one drug has offered the PBM a bigger rebate than the other. It doesn't mean that the preferred drug is therapeutically better for the patient, which I would say is something that patients should be deciding with their doctors. Lastly, you heard that drug coupons drive up premiums. I also want to disagree with that and say that the experience of states that have enacted copay accumulator adjustment bans shows that after those bans were enacted, there was no meaningful increase in premiums. And here, I think it's important to say too that we've heard from our two marketplace insurers, Blue Cross Blue Shield, MVP, that they are already allowing coupons to count, at least on their marketplace plans, meaning that if we adopt this language, we're simply formalizing in law a situation that's already in practice on the ground. So there would be no change in premiums, but there would be peace of mind for patients that their health plan could not simply change that policy at any moment. So now I'm ready for my last slide, which is I've gotten through everything I wanted to say today. Thank you very much for bearing with me. I'll be around for the rest of the week too. If other consumer stuff comes up, maybe you'll give me a chance to say a few more words.
Great, thank you, Maury. And then we're going to have to go to Jeff because we have time.
The HCA recommendations you've already put in writing, correct?
I don't know if I submitted it yet. Yep.
I think I have it, but could you?
I did send it to you. Yeah.
Okay. It's the same, hasn't
It
changed.
has not changed. No. Yeah.
Thank you.
Yeah, you're welcome.
Great, thank you, Charlie.
Thank you, Maury. Yes.
Appreciate it.
Thank you, Charlie.
And if you can just take down your.
Oh,
slides,
yeah, there we
then
go,
can
yeah.
See Jeff.
Yeah.
Hi, Jeff.
Hi, how are you? Can you hear me okay?
Yes, we can. It's
Perfect.
all yours.
Well, thank you, Madam Chair. So I'm sure your heads are all spinning by now. I'm gonna keep my comments brief here and then kind of open up some questions that I'm sure you have. So I'm very pleased to be here today. For the record, my name is Jeff Hochberg. I'm the executive director of the Rutland Pharmacy Group. We have 6 of the 18 remaining independent pharmacies left in this state. Been in operation since 1982. I've spent my entire life in pharmacy and have seen it from, having just going from manufacturer directly to pharmacist to the patient, to having wholesalers, PBMs, insurers, switch companies, GPOs, everything under the sun that now exists in the middle. So I've seen quite a bit, and I think maybe that's where some of this stuff comes from. This bill, H233, is an opportunity for Vermont to not only catch up with what other states are modeling, but lead with something that other states are quickly coming to realize as the next logical step, including the federal government with the rollout of CMS's maximum fair price set to go into effect January of 26. Everyone on the committee has some notion, I think, at this point that there's something misaligned with the current model. Following the money seems to take us right back to where we start. So let's take a quick moment to kind of gain some perspective here. Premium costs continue to climb to unaffordable rates. The main driver of that inflation has been and continues to be prescription drugs. And this is certainly greatly affecting individuals, employers alike. Even our own education system's budget is being impacted by the continual inflation. As state, Regulators know far too little about what makes up costs associated with prescription drugs. Our own DFR is quickly learning, thanks to efforts of our good friends like Sebastian, who I think is sitting there. But I think they still certainly have a long road to go. And they certainly need the proper resources to forge ahead appropriately. Consumer protection rules continue to be circumvented or flat out ignored because there's no mechanism of enforcement. Take, for instance, the price appeal language that this group passed last time with Act 131. Today, we find numerous examples of games with brand name drugs, which PBMs often argue don't apply to said transparency disclosures established by this group. These same brands are being preferred over cheaper generics or cheaper biosimilars because of supposed rebates that no one seems to be willing to identify and certainly not define. And it's causing excessive burden upon providers through prior authorizations or simple supply chain availability issues. Primary care, as you know, it is already stretched far too thin. On the plus side, here we have highly trained and competent professionals like Dr. Bodie who are saying, let them help. Other states and entities are quickly coming to realize that the ability of pharmacists and pharmacies and those entities and states are seeing gains. We see entrepreneurial entities succeeding in offering transparent, reference-based pricing, acquisition cost plus. This year, we even actually saw 2 of the big 3 vertically integrated entities offering up cost plus contracts to commercial exchange payers. All of this, I think, reminds us that there's something seriously wrong here. Slowly, the country is coming to realize that pharmacists and pharmacies can dramatically help remove the inflationary leverage pharmaceutical products impose on our healthcare system. How they can improve community access to treatment and early interventions, and respond to market changes and conditions in real time. The key to all of this is to decouple the fee-for-product model to one of real, transparent cost, much like the model our own Medicaid utilizes, and give regulators the ability to enforce consumer protections. It further provides the state with the data to continue to monitor in real time and evaluate the system as a whole at a key point of access for the consumer. That is what H2233 does. I thank you for giving pharmacists and Vermont community pharmacists the opportunity. Before I turn it over to some questions, I want to just kind of frame things up. In 1982, when my father started Rutland Pharmacy, he bought directly from the manufacturers and sold it to the patients that came to frequent his pharmacy. That's how it started. Ask yourselves what else goes on in the middle between the point of producing a pharmaceutical product for treatment and making sure a patient gets it safely and appropriately. Everything else in the middle is logistical. That is where the problems are. That is what we need to uncover. And just if you frame it in that way, I think it might help you understand how the business elements to pharmacy and how it's viewed upon and impacts to the healthcare system at large can really be changed by changing our perspective and changing our point at which government and regulators insert themselves for inspection. We can control the insurance market on the one side on the premium level, and we need to evaluate what real costs are, which inherently drive up those premiums. So with that, I'll turn it over some questions and see what will come from there.
Jeff, so do you support everything that's in the bill?
I support everything in the bill. I think there's one, and Theo, I think, produced a document that has a lot of our substantive edits. If so, there's one thing that I know we did not discuss upon was the very first item that Jen's slide deck of 189471, which is the definition of maximum allowable cost. If we tweak that, it changes the application of maximum allowable cost definition to be broader and include brand name drugs and biosimilars. That can create market pressure to help identify some of those misalignments. Okay. Now, there's a proposal in the bill for outright banning of spread pricing. Now, I argue that it's technically already prohibited under Vermont statute. If the consumer is not supposed to be charged more than the maximum allowable cost of a drug, then there should not be any spread pricing going on. Because what happens is that when a patient is in the deductible phase, they pay the contract price, that spread price. And then when they hit the benefit stage, the pharmacy is reimbursed the maximum allowable cost of the drug. That is how they hide spread pricing. But it's already prohibited, so I think it needs clarity, and certainly we support that.
Okay, thank you. Any other questions for Jeff? Mari and then Art.
Can you provide language for those tweaks? I'm, while you're talking, trying to go to the section of the bill,
Yep.
tweaking the MAC language. Okay.
Yep, I think I'll submit that.
Thanks.
Art?
Yeah, thanks for your testimony. Something you said really struck me, and that is how your dad, when he started the business, bought drugs. Your dad went to the manufacturer, bought the drugs, and that was that. What mechanisms or what, I mean, we can probably talk for 10 hours on this, but what caused that to change? What, was it governmental regulation? Is it greed? Is it all of the above? What got in the way to cause the system to be what it is today? In your opinion?
In my opinion, it goes a lot to underestimating the value pharmacy has in healthcare. You go as a patient, you go see your doctor once a year for a checkup. Hey, you got high blood pressure, let's evaluate it. Okay, it's clinical, so we should put you on a medication, and we'll see you again in 6 to 8 months. But every single month you go to your pharmacist. Every single time a patient walks into a pharmacy, a pharmacist is there to answer questions, to help guide them, to offer up suggestions, without any consideration to cost or anything like that. They just freely give it. And that's one of the greatest things that pharmacists do. But that data that they hold, the claims data, that is of such value to insurance markets, to stop loss insurers, to data miners. Our prescription information is bought and sold numerous times within the industry, and it's used against us. Your prescription record is used against you when you go to apply for life insurance. They retro-engineer diagnoses based upon your prescription histories. There's so much that can be learned. How frequently patients go to their doctor versus getting refills automatically renewed. How many interventions are actually being happened? How many prior authorizations are occurring? What's the difference between a preferred brand versus the cheaper generic on the market today?
Okay, Jeff, we got it. Thank you.
I could go on.
Any other questions for Jeff? Great, thank you, Jeff. Appreciate your time.
My pleasure. Thank you.
All right, we're gonna talk to Melissa Horn, and then we're gonna take a break. Hi, Melissa, thank you for hanging on with us. I think you're on mute. Or we can't hear you.
Can you hear me now?
Yes, we can, thank you.
Wonderful, wonderful. Well, thank you to the chair and members of the committee for the opportunity to submit some testimony. I submitted written with a lot of great information, so hopefully I can keep it pretty brief for you all. But just wanted to emphasize some of the points around the copay accumulators or the cost sharing requirements that are in H233. We do urge support from the committee to pass this legislation, especially we have 167,000 Vermont residents that have doctor-diagnosed arthritis, and it is the leading cause of disability in the US. So ensuring that patients can have access and be able to pay for their medications is of the utmost priority for the Arthritis Foundation and many disease-oriented health groups out there. So as was mentioned already, a lot of plans have these copay accumulator programs that prevent copayment assistance to be counted towards a patient's deductible or maximum out-of-pocket expenses. So I liken this to if you were a student and you had a scholarship to go pay for your tuition, you were awarded that for your cost as a form of payment for your tuition. You go to the university registrar, you go pay your tuition, they take the payment, but your tuition bill doesn't lower. So this is the point where we are trying to correct, because to us, a payment is a payment, regardless if it comes from a third party, be it a manufacturer or a foundation or other third party. So, you know, when it comes to these copay cards, a lot of them are for the higher cost drugs that have no generic alternative. So the patients that we have across the state and nationwide are usually, you know, pursuing options to navigate pain and reduce swelling. And these drugs can be, you know, infusions or other medications that have, again, no generic alternative. We'd love to see an investment, and there's no patient that I know of, myself included, that would seek a higher cost drug purposefully or be steered to it based off of a name. It's mostly about the effectiveness of the medication and how it works for treating their illness. So currently the state of Vermont does not have a law to ensure that health insurers count copayment assistance towards cost sharing requirements. And of course, this legislation does point that out. And it is on page 11, I think that was noted earlier, that the language in there that would address these copay accumulators. Half of the marketplace insurers in the state have a copay accumulator adjustment program. And it is a common practice that we've seen probably since 2018 across the nation, that insurance plans have adopted these types of plans. It is difficult for the patient to find out that they have an accumulator program. Sometimes they're called like copay armor or other verbiage that can be confusing. I myself, whenever I'm navigating my insurance plan, it's like a control F, a search and find, to see what is in my own plan. And often when you're switching employers, you know, seeing the details of your plan can be hard to navigate. So this legislation, of course, has to do with state regulated plans. And I do want to be clear that there is a difference between assistance, which is a payment, and a discount. So the part of the coalition that the Arthritis Foundation is a part of, the All Copays Count Coalition, is about addressing the payments that are available for copays and making sure that they count towards the deductible and out-of-pocket cost. A coupon or a discount is more about reducing the price at the point of sale. It's not about a payment per se, but these words can be used interchangeably. Again, it's not our prerogative to design how assistance programs are offered, but I do want to make it, you know, clear that we are talking about payments for copays. So again, we don't want our patients to be in copay quicksand. We want to make sure that if they're using a third-party assistance program, that it is counted towards their deductible or out-of-pocket max. Again, you know, our big concern for our patients, those living with arthritis across the state, is they stay stable on their medications. And if they have problems filling their medication and they are using assistance, which are our most vulnerable patient population, sometimes this can lead them to abandoning or delaying filling their prescription. And that's the worst case scenario for us, because we know that from just surveying our patients, we had 37% of patients that reported that they had trouble affording their out-of-pocket costs, and 54% said that they suffered significant financial hardship because of it. Some of these drugs, again, no generic alternative, can be thousands of dollars. So if you're budgeting and you're trying to be a responsible consumer with a chronic disease, you want to make sure that you are anticipating what is coming out of your own pocket, but also, again, if you have any assistance available, what you can put towards that copayment for the year. So, in surveying our patients, they found that if they're faced with a large unexpected charge for the prescription, they didn't expect to budget for it. Their top 3 reactions would be to abandon the prescription, delay filling it, or try to lengthen the time between the doses, or asking their provider to switch to another drug. Now, patients already have to navigate sometimes overly burdensome processes of prior authorization or step therapy where they have to fail first on a drug. And we're not addressing any of that in this bill. Our patients are responsibly utilizing their coverage and going through the steps for their insurance payers to find the drug that will work best for them and treat their swelling, pain, etc., all that comes along with a diagnosis of arthritis. So I think it was mentioned before, 19 states, DC and Puerto Rico have already passed laws to restrict, to ban copay accumulator programs, and we'd love to see Vermont pass this as well. And I've provided some additional information to the committee that addresses that the states have passed these laws. We've not seen significant premium increases, though I will say, we see premium increases every year. It hasn't been that we've noticed from the law changes. They've been on trend for what other states have experienced that do have copay programs. So just wanted to make sure that that was noted, as well as I'm sure you will hear testimony from the payers that this could affect premium prices. So I just want to make sure that first and foremost that the patient is considered as you're navigating policy solutions towards addressing cost sharing. And this is a fix that, again, many other states, all bipartisan legislation, have addressed to restrict copay accumulator programs to make sure that a payment counts regardless of where it comes from. So with that, I would urge the committee to pass H233, and happy to answer any questions or provide any follow-up information.
Thank you, Melissa. I have a question. So 19 states have passed. Do you know how many states might be considering legislation?
Sure. Let me see here. 1, 2, 3. I've got a chart. I got to count real quick. Bear with me. 15. 15 have pending legislation. Okay. Yeah. And we expect some others as well. I mean, some states, their sessions, typically are in an even year like this year, run January to June. So we still do expect some drafts to come up in March. I would say probably add another 3 states to that.
Okay, great. Thank you. Leslie and then Mari.
Thank you for your testimony. Much appreciated. I'm curious about the 19 states. Has there been any unexpected consequences or surprises that came out of this legislation, or any good?
I mean, good for sure. We've had patients, again, that it's less of a burden to have to go and log in and figure out where you are in your copay responsibilities for the year. I mean, I'll just tell you, as I'm a 3-time cancer survivor myself, and often I find myself going and doing the math to see where I'm at for my budget for the year. And that is a significant, report back from our patient population, and that, states that have these protections, if they're on one of those plans, they definitely don't have that extra burden of figuring out what they are responsible to pay. In terms of unintended, I mean, I think you have implementation where we are working with insurance commissioners to report if plans have not adopted within their plan design quite yet. There's always kind of this phase after you pass a law. I would say that first year, and since this is a newer policy area, since 2018, we've had probably 2 or 3 states that it takes several months for plans to adopt this to ensure that they don't have the copay accumulators anymore. And sometimes that takes interacting with the commissioner to enforce that. But overall, once this is passed, we haven't seen any significant problems, just the usual adoption of a new law kind of stuff.
So the regulation should help move that through if we adopt that part. Thank you.
Absolutely.
Thank you, Melissa. I'm looking at the document that you posted or gave to us. It's on our committee website from the AIDS Institute, where The second page has the chart that shows, I just want to be, I think I've got it now. This is what you were talking about when you said that of the states, and they're all in blue, that passed these accumulator bans. The numbers there are just showing what the benchmark premiums were.
Correct.
In general.
Since the law is passed. Yep.
Okay. And it looks like
and of the plans that, you know, are state regulated, obviously. So yeah, you have not seen a significant, you know, increase. There are increases. Every year we see increases, but nothing significant.
It looks like there's actually, not that there's a direct correlation, but there's actually quite a number of them who the benchmark premiums went down.
But this isn't just for pharmacy. This is for
just the average benchmark premiums. Yep.
So could be other factors.
Correct.
Yeah, as I said, not directly correlated.
Any other questions for Art?
Yeah, I'm looking at your testimony that's sent in, the Arthritis Foundation headline, and I'm trying to make sense of the copay accumulator. On the face of it, it sounds like a good thing. But is it that they won't allow the cards to count, the coupons to count? Is that the problem? I'm reading the second paragraph here, and I don't want to take up time here, but it confuses me as to what we're trying to get to here, what the right answer is.
So let's just walk through an example here. Let's say that you had a biologic drug that cost $3,000. And you found either foundation co-payment assistance or manufacturer assistance, that would cover the entirety of that cost per month. Your out-of-pocket max, let's say, is $7,000. You go to fill your prescription, and you use that co-payment assistance card for the first month, and it's covered for $3,000. By the second month, you don't have any left on the co-pay assistance card. So you're responsible to start now on your out-of-pocket max for the full $7,000. So in that plan year, you've now contributed $10,000 towards the cost, because you should be able to count that copay assistance, that extra $3,000 towards your expenditures. Because again, just like a scholarship, that was awarded to you to pay for your drug.
So you're
but
telling
right now,
me,
they're not counting that $3,000 with a copay accumulator. They're saying, no, we haven't recognized any payment from you in that first month. We did process the payment of that copay accumulator card, but we're not giving you credit for that $3,000. So again, the patient has to be able to log in and calculate, okay, well, what did my health plan count for me? And for our perspective from the Arthritis Foundation, again, regardless where the payment comes from, it's a payment. And it's for that patient, and it's dedicated for that drug. So this bill really makes sure that those programs cannot exist in the plans, and that, again, any payment on behalf of a patient is counted towards their deductible and out-of-pocket cost.
Can I clarify something, Melissa? One that was really helpful, and I'm going to try and repeat it here in a minute in a different way, and then I'm going to ask a question. So I need a high-cost drug. And I'm able, I know I'm not going to be able to afford it. So I'm able to go to the manufacturer, because manufacturers have these programs that says, yep, we're going to help you with that arthritis drug. And we're going to give you $3,000 to cover it. And the cost of it is $3,000. So now I go and fill it. The manufacturer is paying the $3,000 to the plan. That's my question, right? The health insurance company is getting that. Someone is paying that $3,000. It's just not me, the patient.
Correct.
Okay. So I go fill my prescription, and I don't have to pay anything myself. And the next month I go to get the prescription, but I no longer have that $3,000. I paid out of pocket, right? Okay, so I paid out of pocket. Where this comes into play is with your out-of-pocket deductible. So if
Correct.
I have a $3,000 deductible that I have to
Yeah.
pay before, the first month
Mhm.
I had this
It doesn't work
assistance,
it out.
it doesn't wipe it out. So the
Okay, that's
Right.
part I missed.
yeah, that's what I figured. So I go in, right, I have so now it's the second month. I am now paying the $3,000, although technically from the patient's perspective, and we're gonna hear from insurance tomorrow, that $3,000 that I got for assistance should have been applied to my deductible.
Yeah, okay. So,
And
Correct,
this
because
would
it's a
do that.
patient.
so much of this is wording,
Yeah.
it gets me, you
Yeah.
know,
It's very
bitches me up,
confusing.
you know, okay.
Did that help?
Well,
Yes, very much so. That's,
Yeah.
because it sounds on the face of it like a copay accumulator is a good thing.
Right.
You know, that would just, you know, take, you know, and
Accumulate it and get
eat
rid of it.
away at the total,
Right.
and then you would be fine.
Yeah.
Of course, that's not what happened.
Yeah.
No, it's never that simple in
Right.
healthcare.
Yeah.
Thank you, Melissa.
Thank you.
no, definitely not. Yeah,
Any other
I
questions?
Appreciate it. Thank you.
Any other questions?
Thank you so much for your time.
Melissa, hold on, we have one last question. Mari?
It could be for you, Melissa, or it could be for any of the other experts in the room. Does the GoodRx app, is that dealing
Okay,
with
so
manufacturer rebates? I saw Jeff's hand pop up. And Melissa, you were gonna say something?
Yeah, so we're gonna let Melissa go, please.
yeah, sure. So GoodRx is a discount program and is often not used with insurance. Though I will say Cigna has adopted it. If you have a Cigna plan, they have included that towards their calculations for cost. But otherwise, in terms of this GoodRx is not a payment. It is a discount program. So this, our perspective again is that actual payment, not the reduction of the retail price at point of sale.
How does the GoodRx thing work? Where
So
are the
what they
discounts?
do is they are crowdsourcing available discounts. So it's basically like an internet scrubbing system where it will scrub available discounts from around the country on a specific drug, but it's not like a, you know, dedicated towards reducing, you know, the cost of a specific plan's contracts. So, I mean, I'm not a representative for GoodRx, but I know that literally on the card, whenever you go and try to use it, it will say that this is run outside of your insurance plan.
So it's just for paying for cash, using cash to buy drugs.
Well, it's not even, it's just to reduce, it's a discount program. It's scrubbing for any available discounts that are out there on this particular drug and reducing the retail price at the point of sale.
Okay, and so that's not part of this bill, so we don't have GoodRx testifying, so I think I'm gonna stop that testimony there. Thank you, Melissa. Jeff, did you have anything that's not related to GoodRx?
It's related to kind of the whole couponing, not really GoodRx, which is more like I said, discount card. The couponing process is automatic. Anytime like most pharmacies have this to date, where their system, when they adjudicate a claim, you walk into a pharmacy, you hand them a prescription, they process it, they send it off to your PBM. Before it hits your PBM, it goes through some scrubbing and a process, and it searches for manufacturer coupons, which are automatically applied. And that's where this language gets at, is making sure that those dollars are attributed to patient costs. But it is an automatic system. It's built in. It's very routine. So yeah.
Great, thank you. Okay, I think we're gonna stop this now. Tomorrow we have a lot of insurance companies, pharmacy benefit managers, I think. We have
Yeah.
PFR. So we'll come back to this tomorrow. We're gonna take a break. Can you do the thing at 4:45? Okay, so we're gonna take a break till 4:45, and then we're gonna come back and we're gonna hear the amendment on the occupational therapy compact. And I'm hoping we will also hear the amendment on the social work compact that came out of Ways and Means. So we're trying to get all that done. So thank you all very much.